Good evening. Welcome. Thanks for coming. So this is, as I'm sure you know, an Insights public lecture. And tonight's lecture is part of a series of events that are actually going on this week, and that's organised between Newcastle and Sunderland universities. And they're all about World Anatomy Day, which we're celebrating during this week. So that is actually the 15th of October, so that's Saturday, and that's actually to do with the death of a very famous anatomist called Vesalius, and so that's why we celebrate during this week. So just some housekeeping as well. Please can we make sure that everybody has their phone on either switched off or on silent. Please, as well, we're not expecting a fire alarm, so if the alarm does sound, then please do follow the instructions. And there'll be stewards, so they'll guide you outside to the car park. If any of you would like to tweet about the lecture tonight, then you can use the hashtag InsightsNCL. And following the lecture, there will be an opportunity to ask some questions. So please feel free to ask some questions at the end. Okay, so I should probably introduce myself as well before we move on. So my name is Ian Keenan, so I'm a senior lecturer in anatomy here at Newcastle. And our speaker tonight is Professor Susan Standring from King's College London. She's a neuroscientist, an anatomist, and a grandma who knows about bones and brains. She taught medical and dental students and surgical trainees for over 40 years and has always championed anatomy as a fundamental component of medical and dental curricula. Professor Standring is a Fellow of King's College London, an Honorary Fellow of the Royal College of Surgeons of England, and last year was elected as an honoured member of the American Association of Clinical Anatomists. She has been the editor-in-chief of the last 4 editions of Gray's Anatomy, which is a role that keeps her in touch with anatomists worldwide. And having seen Susan speak several times before, I can tell you that her talk will be very enjoyable, and it's something definitely to look forward to. So enjoy the talk, and I'll hand over to Susan now.
Well, hello everyone. It's very nice to be here. I'm losing my voice slightly, so if I have to rush over there, that I assure you that's water in there. It's not gin. I mean, I wish, but it's not. Okay. So now then, clicker. Okay, fine. So I'm going to talk about anatomy, and today is World Anatomy Day. I think every day should be Anatomy Day, but there we go. You can see that it's a very visual subject, and what I'm going to do is I'm going to say a little bit about what anatomy is, and then I'm going to take you on a brief journey through time, looking at how we've acquired the knowledge that you can see up there. So the first thing is, if you go onto the net and you try and find out, you type in anatomy, and whatever you do, do not type in anatomy of a cake, you'll be there forever. But what you'll find is that anatomy, it's about taking something to pieces. It's about the structure of something. And I thought we'd start by thinking about human anatomy, and first of all, who uses it professionally? Well, obviously anatomists, although these days we don't wear ruffs, and some have beards, but not all of us. And obviously clinicians and healthcare professionals, and they use it in a very specific way. They use it to examine patients and to interpret the findings. So, for example, here you can see this is obviously a very nasty fracture at the bottom end of the femur, which is the big long bone in your thigh. And you can see you've got some nasty bony fragments here, and this bit has been pulled back by the muscle attachments. And there's a red thing there, which is a blood vessel behind. So that person has some problems there. We also need to know some anatomy to undertake procedures safely and effectively. And what you can see there is a lumbar puncture where a needle is introduced into the subarachnoid space to remove cerebrospinal fluid. And you need to know your anatomy there, exactly where to put the needle. You certainly don't want to put it up too high. But it's also, and it might surprise you, that anatomists and engineers and surgeons work together to develop new procedures, new ways of getting to a structure, and developing new instruments. And in fact, this was a very recent paper, Can Anatomical Feasibility Studies Drive Neurosurgical Procedures? To which the answer is, yes, they can. So you can see that anatomy is an important component of what a clinician does. But there are other people who also use anatomy. Archaeologists, forensic scientists. Probably the first question that most archaeologists get asked on a dig is, did this Roman soldier go down to the Roman equivalent of Kentucky Fried Chicken? Is this chicken bone or is this a human bone? So that's a very important thing that they do. But there are other people too. There are artists and sculptors. Animators know a great deal about human anatomy and how people move. Facial reconstructors. And I was very struck the other day, someone pointed out to me in the Times the obituary of Tony Hunt, who was a structural engineer. And, oh, sorry, I pressed the wrong button. Whoops, how do I go back on this? Okay, he was a structural engineer, and he was involved in building the new station at Waterloo, the Eurostar station, and he had taken his inspiration from the anatomical diagrams in Gray's Anatomy. So I thought, big cheer for that. So there's a huge range of people then who use anatomy in their professional lives. I could actually at this point add a plea that everyone should be slightly anatomically literate, and I might come back to that at the end. Now, anatomy anatomized, and this would apply in essence whether you're a vet or a clinician, a human clinician, or whether you're a botanist looking at plants. If you're taking the subject apart, what does it consist of? In case you wonder what anatomized, what that verb is, if you were a felon who had been hanged in the 18th century and your friends had not managed to take your body away, your body would be taken off to Surgeon's Hall and it would be cut to make sure your heart was no longer beating, and then you would have been dissected. You would have been anatomized. That was a post-mortem punishment. Not only would you be humiliated by being hanged, you'd be cut into small pieces. But when we think about anatomy, topographical anatomy is where things are, the muscles, the bones, the joints. And the questions that you have always is, what am I looking at? What is that? Where am I in the body? What can I see? What can I feel? If you feel around your wrist, for example, or feel your elbow, you can feel some consistent bony points. If you look at your wrist, you can see some lines, some flexure lines there. They're things that can be used. And if you're wondering what those pictures are, well, you're listening to me. Whoops, I have to get used to this. I'm sorry about this. You're listening to me. That's your eardrum. And that little tiny bone there is your malleus. It's the first of the three little bones that take the sound waves from your eardrum across to your inner ear. And if you look at your little fingernail, the three little bones in that chain are smaller than your little fingernail. And then you're looking there. There's a transverse section looking from the feet up. There's a liver, there's a spleen, there's a pancreas. That great computer there is your spinal cord, or the spinal cord, and that is looking down into your trachea through the larynx. I have to be very careful what I say about this because I have sitting in the audience a great friend, Professor Stephen McCanwell, who's forgotten more about the larynx than I will ever know. But those are pictures that you're looking at and you're thinking, is that normal? Do I know what that is? Should that be there? Has it been distorted by underlying pathology? So all of those things are going through your mind. And then there's developmental anatomy, which is how, the clue is in the name, it's how something develops. And here, for example, we have wonderful pictures of the development of the brain. And here, second trimester ultrasound images, which are taken for measurements that can be taken to say, are those structures in the right place? Are they the right size? So the questions you're asking there is it in the right place? How did it get there? For example, your thyroid gland, which you probably know is down here, but it didn't start down there, it starts at the back of your tongue. And for a lot of things that migrate in development, they sometimes don't start, and they sometimes go too far. Sometimes, very few people only have thyroid tissue in the back of their tongue. and the little duct that the thyroid takes to get down to its final position, sometimes that doesn't disappear. So you might have someone come to you and say, I've got this lump in the middle of my neck. And do you know, when I stick my tongue out, the lump goes up. And you think, yes, because it's still attached to the back of your tongue. So developmental anatomy then is looking at how things develop, how cells differentiate. Timing is terribly important because some cells have to cross the midline. If they get too early or too late to where they should be crossing, they can't go. How did it get there is a question that you're always asking. And then there's cellular and subcellular anatomy, which when I was a lad was called histology. And that's what you see when you look down a microscope, any kind of a microscope, a light microscope, an electron microscope. That is looking at skin, very thick skin there. And that's looking at a little blood vessel. And those funny little dumbbell-shaped things are your red blood cells. Now, each one of those is about 7 microns across. A micron, for those of you not too sure, is 1,000th of a millimeter. So they're very tiny. But again, it's what am I looking at? Is this normal? And most clinicians will need to know the topographical anatomy. The developmental anatomy is really the province of the pediatricians. And the cellular and subcellular anatomy is the province of the pathologists. And the old name for pathology was morbid anatomy. That was the anatomy of dead tissue. Now pathologists will spend a great deal of their time looking at biopsy, which is taken from the living. So that is anatomy. And as I said, a vet will be asking the same things about topographical anatomy, about developmental anatomy, maybe of a calf or a foal. We'll be looking at pathology. And a botanist will do exactly the same. Now, the language of anatomy is very complicated, and when I was at med school I remember being told, you're going to learn 15,000 new words. I thought, I didn't come to medical school to learn new words, but here we go. Just to take you through the language that is used. Sometimes things look like something else. They look like a worm, the appendix. They look like a sieve. Something in the brain that looks like a hippocampus. Seahorse. I never thought it looked like a seahorse, but there you go. The pituitary sits in the Turkish saddle. Sometimes it's named after the person who first described the structure. At least that's the myth. Very often it's named after the person who has the best PR. But we'll come back to the circle of Willis in a moment. Sometimes it's the position. Suprarenal means above the kidney, for example. And sometimes it's function. Flexor digitorum superficialis. You can see where this is going. I'm trying to get you used to the fact that an awful lot of anatomical language is Latin. Flexor digitorum superficialis is the flexor, the superficial flexor of your fingers. Sometimes it's named after parts of a building. There's a lovely idea that the body, you can see over here this beautiful picture from Katz, that the body is like a building, so that you can talk about the attic, which is actually in the middle ear, the antrum, the tectum, which is a roof, or the fornix, which is an arch. And if anyone is interested, there's a marvelous book called The Secret Language of Anatomy by Cecilia Brassett and her colleagues, and it takes you through extraordinary names of agricultural, military, domestic. But that's our language. And we also use orientating planes. We have to do that in order to describe structures, a front, a back, a top, a bottom, its sides, and movements, whether they're flexion or extension or whatever. When I used to teach first-year medical students, I would always start my introduction with a green watering can, because it had a spout and a handle and had a label on one side and it had all sorts of things. So I could explain all of the anatomical topology that way. And many years later, I met a young consultant, and the first thing he said after saying, hello, Professor Standring, was, you're the green watering can lady. I thought, if that's all the anatomy you remember from my lectures, okay, but there you go. So that's just very briefly what anatomy is. Now let's just see how we got some of that knowledge. Looking inside the body. And what I'm going to do, I've divided this up into serendipitous, intentional, and Claudius Galen's going to come in here, and then I'm going to talk about some very important paradigm shifts in our knowledge. Then the impact of increasing regulation, and finally the impact of technology. Now, to start with, if I gave you a box that was full of something interesting, but it had a lid on it, and you sort of shook it, the first thing you'd say is, well, what's inside? Can I open it up and have a look? Well, that's the one thing you couldn't do when things first started in anatomy. You couldn't look inside the body. You couldn't deliberately dissect it. for religious and legal reasons, the body had to remain intact. So the views that we had initially inside the body were serendipitous. They weren't done for the reason of finding out the anatomy. So, for example, the priests in the pyramids, when they were setting about going to embalm the pharaoh, they would take out the lungs and the liver and the small intestine and the stomach, and they put them in jars, but they wouldn't look at the body. The heart they left, by the way, and the brain they pulled out through the nose because the brain wasn't important. For our politicians, of course, that's still the case, but never mind. I've just realized this is being recorded. I'm sorry, Miss Trust, I didn't actually mean that. And serendipitous, of course, always surgery and anatomy have advanced in the military sphere, because that's until relatively recently when people started slashing each other on the streets. But initially, you'd see the most serious injuries on the field of battle. And so here we have slashing and cutting wounds from swords, could be quite deep, exposing internal organs, so that the military surgeons could actually look inside. And here, this is a fresco from Pompeii. I wouldn't want this as a fresco, but it's Iapix removing a spearhead from Aeneas's thigh. That was a way in which, again, you could look inside, you could see things, but you didn't know systematically what was going on. And then I love this one. These are the nuns of Montefalco who used to open corpses, particularly their abbess. What they were looking for, well, they wanted to know what made somebody holy. So those were the very early views, serendipitous views into the body. There was one very short period when dissection was allowed, and that was Herophilus and his pupil Erasistratus, and they were working in Alexandria in Egypt in the medical school. And the Emperor Ptolemy, for some reason, maybe he wanted to dissect himself, he allowed them to open bodies. And it is said that they vivisected slaves. That may have been put about by their political enemies, but they certainly dissected bodies. I can't guarantee those are the knives they used, but that is from the period, the only knives I could find. And they started naming things. For example, the duodenum, which is 12 fingers long. And this was the only time of which we know when human bodies were systematically dissected. Now we're moving forward a little bit to a very famous man called Claudius Galen. He was born in Pergamum, which is now in southwest Turkey. And he dissected, he was a surgeon. He was a surgeon to Marcus Aurelius, the emperor. He was a surgeon to the gladiators. He did have a skeleton, which he had, I think, taken from a rotting body by the roadside, and he'd got a skeleton. But he produced about 60 works on medical practice. He dissected just about every animal that moved, particularly apes and monkeys, oxen, elephant. He had one, if not two elephants. He complained that he couldn't dissect flies and spiders. They were a bit too small. He produced, he dissected and vivisected in public, challenging other surgeons to do what he could do, and he described the anatomy in great detail. The problem was, none of it was human anatomy. But he produces a book called On the Use of the Parts of the Human Body, and that book was still being used in 1625. It was still being used in the 17th century as a book of anatomy. Everyone assumed Galen had seen it, Galen had described it. This must be what the body looks like inside. So I'm now going to compress a lot of history into one small slide, and with apologies to J.R. Tolkien. What happened after the fall of the Roman Empire was that all of the work from the surgeons who'd been working in and around the Mediterranean, the Greek, what wasn't destroyed, traveled east. The books were taken east. They were translated into Arabic. They were kept in the great library in Baghdad. And Galen's text was there. It was modified by some of the Islamic and Arabic physicians, including Avicenna and Rhazes, and what was known as the golden age of Islamic medicine. But it was still ostensibly Galenic medicine, Galenic anatomy. They modified it a bit, but there is no evidence that they dissected. And then very gradually, around about the 11th century, these texts start to filter back into Western Europe, and they're translated in Toledo, the great translation school there, and in Salerno, and they're translated into Latin, hence the fact that the language that we use is still Latin. But it's still mainly Galenic. So this is bringing us up now into the 14th century. Okay, and for the first time, dissection is allowed, but only one or two bodies, and normally nobody you know, they've got to come from outside the city walls, so you wouldn't recognize your neighbor. And the first person that we know who does this is a man called Mondinus. And what he does is he's undertaking an autopsy, which always seems to me very strange. How on earth can you undertake an autopsy looking for something that's abnormal if you haven't the faintest clue what the normal looks like? But that's just a minor point. So he is known as the restorer of human anatomy. He is allowed to dissect, and he translates his own version of Galen. This is a much later printed copy, that's why I've highlighted the date, but the important thing is the picture. Look what he's doing. He's sitting in his professorial chair, he's reading a book. He really doesn't mind what the chap dissecting finds, because whatever he finds, if it's not what Galen says, it's not right. Okay? Galen was right. Maybe the body's changed since Galen's time, but Galen's right. If you ever see this in a hand-coloured version, he's sitting in a field surrounded by trees. It's a very odd picture. But there are several other pictures from Dicetum, for example, which give you exactly the same impression. What matters is you are seeing what you believe. And these are some of the views that you might see. The only one at the end is printed, but there's a sort of impression in some of those that somebody somewhere at some time must have seen or described a dissected body. Most of these you see, there are 5 of them, and you see them interleaved in copies. This is interesting, and I've put down there, it could even have come as a description from Herophilus and Erasistratus, but otherwise it's Salerno, which was the first medical school in Western Europe, and up there we have for the first time, there's a little brain and a ventricle. Now the reason I've included this is a printed version, but it's not a printed anatomy book, and I'll come back to what those funny things are there. But just look at that. It's called a situs figure. Someone has said, well, there's a heart and a lung, and there's some guts, and there's a thing called a diaphragm. But when the second edition of this book came out, obviously the engraver had copied the picture, and a bit like a potato cut, you know, he dipped it in the ink and he'd stamped it, and it came out the other way around, and nobody had any idea that it was different. So that was just about how much anatomy they knew. At the same time that this was happening, Leonardo da Vinci was drawing his anatomy drawings, but I'm not going to talk about that because nobody knew about them at the time, but they were a world apart. However, paradigm shifts. We're going to just get a little faster here in terms of progress, and I thought I'd better make sure I know what a paradigm shift is, because we all talk about them. It's an important change in a basic concept, an experimental practice. So we're now moving forwards, and during this time we're going to leave Galen behind. The first thing is, as I mentioned right at the beginning, the people who are very keen on anatomy and knowing anatomy are the artists. And that was certainly the case in Florence during the Renaissance, the beginning of the Renaissance. This is a wonderful copper plate engraving by Antonio Poleolo. And we are told by Vasari that he was the first person who actually skinned bodies to look at the muscles so that he could drape the skin as it should be and produce a very much more modern-looking semi-three-dimensional picture. This is actually in the Victoria and Albert Museum. I go there at least every month or so, and I always go and check that it's there. It's right down low, but it's an amazing picture. Because when you look at it, if you compare it with, say, 13th century pictures, which are very flat and tend to be very religious, this is very different. And they're different because by that time, Leon Battista Alberti had codified linear perspective, and Gutenberg had invented movable metal type printing. So we've got a whole different feel about the information that we have here. Now, this is a drawing possibly by Raphael. The story goes that a young surgeon called Jacopo Berengario in Bologna was treating a judge who owned this drawing. And Berengario said when he'd finished treating him, I don't want any money, I'll have that picture. And the next time we see that picture is in the first printed anatomy book by Berengario. Yes, the body is wandering around in the Tuscan countryside. This is a fashion for a while, but get over it is all I can say. Berengario was an extraordinary guy, apparently had a foul temper and was a poet and a surgeon, but he did his own dissection, and he says, A good anatomist doesn't believe anything in his discipline simply because of the spoken or written word. What is required is sight and touch. He had a few digs at Galen, but he didn't, I can talk about it later, he didn't actually have the right reasoning to have a dig at Galen. But these are some of the pictures that he produces, and they are recognizably human. I mean, I couldn't do that, but my students would tell you I couldn't draw a straight line, so there we go. But the other thing that Berengario does, because he was very interested in the brain, he had extraordinary ideas about what concussion was. He said, I believe that concussion is when the brain moves inside the skull, which of course is absolutely right. And he gives us the first picture of the brain. Now, if you think about doing that, you've actually got to take off the calvaria, which is bone. You've got to saw that off. You've then got to split the dura and show you the surface of the brain. So there's the dura. And then he sections the brain. They didn't take the brain out very often. He sort of slices it across. Remember, this is not fixed. So that is his first picture, which is pretty amazing. Moving on again. This is a student who is very fed up. He's in Paris. He's a Flemish student. He's in Paris and he's complaining about the unskilled barbers who are his tutors. First of all, the casual and superficial demonstration of a few organs presented to me and my fellow students in 1 or 2 public dissections. And then he says, aside from the 8 muscles of the abdomen, badly mangled and in the wrong order, no one had ever shown a muscle to me, nor any bone, much less the succession of nerves, veins, and arteries. I must say in passing, that thing about the wrong order always makes me think of Eric Morecambe, and Andrew Previn. I'm playing all the right notes, but in the wrong order. But that person, that student, he's so fed up, he leaves Paris. There's a war about to start anyway. He goes rather a circuitous route, and he ends up in Padua, which was then the epicenter of anatomy in the 16th century, and his name was Vesalius. And he became the man who ultimately said Galen didn't dissect humans. We regard him as the founder of modern anatomy. He starts life as a Galenist. He translates Galen with his tutor. He comes to Padua believing in Galen. He undertakes a great many dissections, and he ends up producing an extraordinary 7-volume book. It's a very big book. It's about this size. I remember the first time I opened one in Philadelphia. It's one of those moments when the hairs on the back of your neck go up, because it is an extraordinary experience. It's about the structure of the human body. And look at the difference, quite apart from the fact that he's surrounded by people like Galen and Hippocrates. But look at the difference. What he's doing is he is actually doing the dissection. He's not sitting in a chair reading a book. He's doing it. And he's pointing with one hand at the dissection, and the other one he's pointing upwards. And he produces, or it's possibly Titian, possibly von Kalkar, but from the school of Titian, he produces the most extraordinary diagrams. These are called the muscle men, which are dissected. They're still wandering through the Tuscan countryside, but there you go. But actually, they come all the way through until the final one is just collapsing. All the muscles have been removed. I have to tell you this one. I was in Sicily in a conference in Syracuse about 5 or 6 years ago, and I'd gone one evening down into the crypt of a church and one of the little rooms, and I suddenly realized that on the wall of this crypt was a copy of that, which was quite an amazing experience. But Vesalius, as he is dissecting, and in his book, he says, Galen could not have been dissecting humans. Too much of this is like a dog, or it's like an ox. So he writes that Galen was wrong. He also reminds us of the very close links between the law and anatomists and surgeons, because in his diary he says to his students, well, if I don't finish the leg today, tomorrow we shall have another body. I believe we will hang another man. Yes, he knew very well they were going to hang another man, because he was very friendly with the judge. But he has said Galen didn't dissect humans. Can you imagine today if someone had said, someone who's been famous for 1,500 years was wrong? Can you imagine the Twitter storm there would be? I mean, I say someone who knows nothing about social media, but I know enough to know there would be hell on earth to pay for that. But in fact, he was criticized hugely by his colleagues and his professors, I suppose because they had made their success in their profession using Galen. And he only actually has 2 editions of his book, and then he's so fed up he leaves. And in fact, he died and is buried on the island of Zakynthos, as Ian mentioned. But he had started, and people said, okay, fine. He was plagiarized sufficiently, although he complained to his printer about this Operinus in Basel. He was plagiarized, but thank goodness he was, because people started to read and think, oh, okay, this makes sense. Let's do this for ourselves. And in those days, anatomy was a very public thing. This is a bit like sort of the modern equivalent, I suppose, of Glastonbury or something. You went along to a public dissection, and you had a banquet, and you had music, and you met your friends, and maybe some illicit liaisons, who knows, but that's how people learnt some anatomy. Or you could have pop-up books. Don't think pop-up books are modern inventions. They're wonderful, some of these. You can flip the pages, you can take out, you can dress the figures, or you could look at wonderful wax modeling. Zumbo, who was a Sicilian, you can go all the way through to Joseph Towne in the Gordon Museum in London at Guy's. Or you could look at these incredible little bone or ivory mannequins, and you could take the bits out. I think some of these were actually used for midwives to show them what was inside. So anatomy at this stage is a very public activity. Now here's the second and just as important paradigm shift. Someone who's going to change the way we think about the brain. And his name was Thomas Willis. And he was a physician working in Oxford with an extraordinary group of people, including Christopher Wren and Robert Boyle and Richard Lower, in a group called the Invisible Club in Oxford. He said, I addicted myself to the opening of heads, human heads, cadavers, and also animals. And he produces an extraordinary book. It's called The Anatomy of the Brain and the Nervous System. It's written in Latin, and it's illustrated by Christopher Wren, who you might think of, oh, didn't he design St. Paul's Cathedral? But before that, he was a mathematician. He was a civilian professor of astronomy in Oxford. He was an amazing polymath. And why Willis is famous is that around here, he was very interested in the blood supply of the brain, and he said, look, there are 4 big arteries that supply the brain. What happens if one of them is blocked? And having done a number of experiments, he showed that, in fact, there was this circle of vessels around here, taking from the 2 vertebral arteries and from the internal carotids, and it's called the Circle of Willis. And we can look at the Circle of Willis. This is in a dissection. There's the pituitary stalk. You're deep inside the skull now. The optic nerves would be going through there to get into the orbit. And there is the circle that he described. And today, of course, we can see that on an MR angiogram. But Willis did more than that, because that is, if you like, describing what he's seen. But he gives us the word neurology. He gives us the Circle of Willis. But he also starts to move into a very much more empirical, observational mode of undertaking medicine, because he's correlating his clinical observations with the post-mortem findings. I think Richard Lower did the post-mortems in the local pub, as you do, health and safety having not been invented. But Willis says, you know, we're not thinking about the brain in the right way. The higher cognitive functions of the brain are going on in the brain tissue, not in the spaces. Up until that time, it was thought, remember I showed you that Paley diagram, it was thought that the ventricles inside the brain, which are the spaces, that's where all the important stuff went on, and the rest of the brain tissue was just packing, sort of protecting them. It was assumed that vision and hearing and taste and smell came into the brain, into the ventricles, and somehow was laid down as memory and reasoning and logic. It was rather like the law courts. You brought the evidence in, you assessed and analysed the evidence, and then you gave a decision. And Willis said, no, that's not what's happening at all. Willis said, look, the foldings of the brain, I've looked at the brain, I've looked at the foldings, I can correlate too many foldings or not enough foldings or smaller foldings, and changes also in brain structure with what I see in my patients: mental retardation, learning problems, paralysis. And he said what's going on in the brain is mostly what's going on in there. It's the structure of the brain. It was a huge paradigm shift because it changed, as I say, everything that we think about the brain. Nullius in verba. you may or may not know, is the motto of the Royal Society. The Royal Society, which really started after Christopher Wren's lectures in Gresham College, and Thomas Willis became a fellow in 1663. Nullis in verbia, it says, take no man's word for it. In other words, do it for yourself, which is what goes through all of these great men. Every time they said, I'm doing this for myself. Increasing regulation. Okay. Moving forward now into the 18th century, you guys are all medical students or surgical students, and you're sitting in your coffee shop, chatting, and reading the London Evening Post in 1746, and you see this extraordinary advertisement from an up-and-coming physician, William Hunter, who would go on to become one of the obstetricians of the age. He delivered 14 of Queen Charlotte's 15 children. He's even more famous younger brother is known, John Hunter is known as the founder of the scientific basis of surgery. But what William Hunter is advertising here, he said, I've just come back from Paris and I can teach you anatomy where you're going to be dissecting for yourselves. You're not going to have someone read to you. You're not going to watch a professor mangle something. You're going to do it for yourself. And there is William Hunter sitting. This room doesn't exist, but it's illustrating what went on. And the significant there is prices for bodies, because suddenly you need an awful lot of bodies. You need something like 600 bodies in London alone. Well, they didn't hang that many people, not sufficient for that, even with what's called the Bloody Code, which made all sorts of crimes capital punishment. So the body becomes commodified. And we have the rise of the body stealers and the resurrection men. And there is Dr. Hunter. Hang on, there's Dr. Hunter, and he's running away. The beadle, the night watchman, is ringing his rattle to say to people, look, this body has been stolen. In fact, barely a crime to steal a body, but a tremendous crime to steal the grave goods. And over here we have from Dr. Knox, 1828 in Edinburgh, advertising his course in practical anatomy. Arrangements have been made, nudge, nudge, wink, wink, to secure as usual an ample supply. I mean, that ample supply might have come up from London, bodies pickled in wine and brought up in barrels. Who knows? But clearly, this is crazy. To provide the bodies for dissection for the surgical trainees, it was a totally illegal practice. They made a huge amount of money, the resurrection men. They could make more in a week than a silk weaver in the East End of London can make in a year. And they could supply bodies of children. Beyond a certain length, the child was measured, I think it was sixpences for a foot or something. I'm not quite sure, I can't remember. But as you can imagine, something must be done, and as is the way in all things when enough people say something must be done, there was a select committee set up. Now, quite importantly, that select committee had two functions. One, it was to look at the activities of the resurrection men, and two, it was to see what could be done to help the anatomists and the surgeons who were being criminalized by receiving these bodies which had been recently disinterred by the resurrection men. They were criminalized for trying to find out more about their anatomy so they could help their patients. So if you have time, there are several select committee reports around this time which all say the same thing. There's one on anatomy, there's one on technical drawing. They all say the same thing, which is, yes, we could do better. They do it much better in France and Germany, but we won't go there. Don't anybody mention the European Union. But this report, so Astley Cooper was then probably one of the most important surgeons in Europe. He was then the president of the Royal College of Surgeons. And this is one question he was asked. And I put it in full because it's so important, and you'd ask the same question today. Can a student know when to cut with freedom, when with caution, and when not at all, if he has not an intimate knowledge of the structure of every part of the human body? Remember, the only opportunity the student has to learn anatomy is not computer-led, it's dissection. And so Astley Cooper, it's a very long response, and I've just taken out the bottom of it. He must mangle the living if he has not operated on the dead. He says, I wouldn't be in the same room as anybody who tried to do it. So that's really rather important. And we get, in the end, a little bit later, we get the first Anatomy Act. And you see what it is? It's William IV. It's an act for regulating the schools of anatomy. Not medical schools. At this stage, they are schools of anatomy. And it's worth reading again what it says because it reinforces the importance of anatomy. It says, a knowledge of the causes and nature of disease, of the best method of treating and curing disease, of healing and repairing wounds, cannot be acquired without the aid of anatomical examination. When I was head of department, I often used to think, I wish my dean would read that and understand quite how important anatomy is, because anatomy tends to lose out. And it also says, item 10, it shall be lawful for any professor, teacher, or student of anatomy to receive or possess the body of any person deceased. In fact, slightly unfair because most of the bodies they received came from the workhouses and the poorhouses, and so there was a lot of resentment about this. But we have increasing regulation and legislation of medical education, and we then have the Medical Act. We've now moved on to Queen Victoria. And what this is doing is regulating the qualifications of practitioners of medicine and surgery. So suddenly, you need to take exams. You need textbooks, you need curricula. Anatomy now has gone behind the walls of the medical schools. The anatomy schools disappear. And in fact, in 1858, when this came out, we also had the GMC was established. In 1858, that's obviously a more modern version, but it's just to say that the GMC is still one of its remits is to look into the state of medical education. Just in passing, it's interesting that in fact the first register didn't come out until 1859. They had sort of the equivalent of a computer crashing. So many people wanted to register that they couldn't get the book out in time. But I couldn't not put in Gray's Anatomy. There is 1858. I mean, the publishers must have been delighted. It just happened to coincide. Henry Gray and Henry Carter from St. George's brought out the first edition of a book which not until quite on into the 20th century became known as Gray's Anatomy. But the reason I wanted to put it up was because of what Gray says in his preface. He says, this work is intended to furnish the student and practitioner with an accurate view of the anatomy of the human body, and more especially the application of this science to practical surgery. By 1858, you could anesthetize your patient. 1846, we start to see anesthetics. So suddenly you can put a patient on the table asleep. You don't have to tie them down, hold them down, and they scream in agony while you try and do something, normally amputate, as fast as possible. They're now anesthetized. So Gray is talking about accuracy. He's talking about the application of a science to surgery. And this is a drawing from the first edition, and that's a more modern drawing, computer-generated, but we haven't changed very much. The accuracy was there by the time Carter had come along. One of the things that Carter did, which we now take for granted, is that Carter introduces leader lines and labels. Before that, there's one person who did this before, Hudson, but in fact, to do this consistently, Carter started this phase. So you no longer have little tiny letters, alphanumerics, and you've got to go and look up a code somewhere else. So this was rather important. Now, the impact of technology, it feels like we're in a science steam train that's going faster and faster and faster. We've come through Galen, we've come through Vesalius, we've come through all of the legislation, we're now in the medical schools. I look at that date and I think my grandparents were born before then. I know I'm very old, but even so, it just reminds us how close this is. This is X-ray, a hand with a ring. This is actually Mrs. Frau Bertha Röntgen. But the report here says Professor Röntgen has succeeded in photographing a man's hand, which showed only the bones, the flesh being invisible. That was a little bit later. The first thing that Röntgen photographed actually was his hunting gun, because he thought the stock had a crack in it. And then he photographs his wife's hand. And it's extraordinary because you had to know some anatomy to interpret this. I mean, if you just looked at that, you might guess the ring, but to know what those were joints and to know what was going on there, anatomy was already... We knew this, but now you can see it without having to open up the body. And in fact, news of this went around the world very quickly, and the clinicians very soon got hold of this. Here we are in November 1895, and by January 1896, here's young Eddie McCarthy, who, a foolish boy, had fallen over and fractured he's got a Colles fracture, the end of his radius. But you can see the clinicians thought this was wonderful. We can actually now start looking at our patients just by taking x-rays. I think the anatomists weren't so terribly keen because they knew it all. At this stage, we weren't moving forwards. This is a cadaveric arm which has been injected with lead paint. But yes, the anatomist said, well, I know that. So it took a little bit longer for this to come mainstream for the anatomists. But imaging anatomy today is X-rays, CT, it's MRI. I mean, it's extraordinary what can be done today. And ultrasound, that's a 20-week fetal head, normal. And ultrasound, nobody would think today, no anaesthetist would think of administering a block. This is an interscalene block into the neck, aiming to get a local anesthetic solution around the brachial plexus to numb the upper limb. Nobody would think of doing anything like that today without using ultrasound. But all of that, of course, is validated by knowing your anatomy in the first place. And I was very interested a few years ago, in 2014, this paper came out, Are Radiologists the Contemporary Anatomists? To which Professor Standring shouted yes very loudly, because they know so much anatomy. And I thought I'd just illustrate a little bit more, just taking the brain as what you can do with imaging. When I was a student back in 1964, if you x-rayed a patient's head, you couldn't see the brain. And I have to say again, that is not a politician's head. If you wanted to look at the brain, you had to take the brain out and have a look at it. You had to section either sagittally or horizontally. And then along comes MRI. And much to every student's horror, you can see all that detail in the living patient. And what's more, you can turn it any which way. You can go between like that and like that and like that. And you can scroll through. And you can do more than that. The brain is full of fiber tracts. Thomas Willis didn't quite get that far, but he knew it was full of all sorts of interesting structures. And in the old days, if you wanted to look at those fiber tracts, again, you had to look in a cadaveric brain and dissect it. And you had to correlate that with what is known from experimental studies. But today, you can look at the fiber tracts like that. Now, those are not fiber tracts. This is what's called diffusion sensor imaging. And these are probabilistic maps of the diffusion of water molecules along longitudinal fibers. But if you know enough anatomy, as the radiologist did, you can use your knowledge of the anatomical tracts to validate what you see. And DTI is used all the time now. We can also use modern imaging to look at the development of the folding in the brain. We can look, as we've seen there, at the vessels. We can either look at the circle of Willis, or we can look here both at the veins and at the arteries. And that's all structural MRI. We can also look functional MRI. You can ask the patient to do something. It's called blood oxygen level dependent imaging. In this case, someone's been asked to wiggle their fingers on their right hand, and what happens is that we see lighting up on the left-hand side. We can see in the motor cortex there, the finger area lighting up. So you can actually give people tasks to do, and you can start interpreting functional MRIs. There is, and some of you may be interested, and I've just put the URL down there, it started some time back now in the States. It's called the Human Connectome Project, and it's mapping the pathways. I mean, Thomas Willis would have loved this, can't you imagine? To underline the human brain function, looking at structural and functional connectivity. And in fact, there's some fascinating papers just coming out, looking not just at the pathways, but looking at circuitry as another way of looking at the brain. And I thought I'd just remind you that there's something like 86 million neurons in the brain. That's not including all the blood vessels and all the supporting cells, and about 100 trillion synapses. I think the Office for Budget Responsibility should look at that, but there's very big numbers. But it just gives you a sense of how complicated this is, and how we are really, I feel, just in the foothills here, but how far we have moved, and how much just standard anatomy is used to help validate all of these techniques. And then, of course, we can look inside out, endoscopic anatomy. If you're dissecting, you're looking outside in. But you can, of course, now. You don't have to have it. It used to be the bigger the surgeon, the bigger the cut. It's not the case anymore. And so we have looking into the knee. So there we're looking, there's the femur, there's the patella, your kneecap. And if you look there, looking through into the knee there with the endoscope, and that's the tibial plateau there, which has got a little tear in it. So arthroscopy, again, cutting down the time that the patient is being hospitalized. You can even swallow a little capsule which you have on your belt. You have a little receiver and a little camera in the capsule, which you swallow as it travels through your small intestine. It sends back pictures. I'll leave you to work out what happens to the little pill when you get to the other end. Okay, and then I've only got two slightly bloody pictures. This is what you see laparoscopically down in the pelvis on one side, and what you have here, that's the external iliac artery, and there's the vein. So surgeons have to get used to a very different view and a different perspective, because you're looking at a screen. You walk into an operating theatre now, and you're far less likely to see a body on a table with a big hole. You'll just someone's looking at a screen. I mean, I've actually seen a prostate operation done where the surgeon was in Sydney and the patient was in Guy's Hospital. So all you need is a wireless connection. So this is a very different way of looking at the body. But again, you need to know the anatomy, and then you have to go back and relearn it and say, okay, what are my landmarks? What am I looking at? So I love this quote. This is in Massachusetts. They were obviously having exactly the same problem about what do we do about cadavers and about dissection. But the reason I've put this up here is to say that today you're as likely to see surgeons in a dissecting room, and dissecting rooms that look almost like operating theatres. Because what they're doing is they have clinical problems and they want answers. How can I better understand? How can I access that structure? What do I need to know to interpret what I find? And I'm just going to share with you one or two anatomical maps, starting also with their other aim is how do I know enough anatomy to prevent injury? Right at the beginning, I brought in that magic word safety, and that is everything that's important, everything that clinicians do ultimately is first do no harm. It's always very interesting when you get very bright medical students who for the first time in their lives fail an exam. Why did I fail that exam? Because you don't know enough. And it's our responsibility to make sure you are safe to proceed, because you're dealing with real people. You know, a surgeon makes a mistake, all sorts of terrible things can happen, so they have to be safe. Iatrogenic injury means an injury caused really by the surgeon. Or it wasn't there to start with. It's an old idea. This is from a wonderful atlas by Braun, which they took bodies frozen in the snow, sectioned them, put tissue paper over the cut surface, and then traced it. But you notice here it says, in order that the observer may avoid mistakes on the living body. And I thought I would just put this here just to persuade you that this is still the case. This again is laparoscopic. You're right up here, if you can imagine, inside, just under your clavicle, there is the lung. Okay, this is obviously not a smoker. Okay, there are the ribs, and they're just coming down there, the thoracic sympathetic trunk. But what the surgeon is saying here is a thorough knowledge of the anatomy of a whole bunch of nerves that are really very important is essential to prevent their injury during surgery. And there are very few surgery textbooks, very few papers on surgery, which in some place will not say, you must know the anatomy, otherwise you have no business being there. Think back to Astley Cooper. If you're in tiger territory, you've got to know how to deal with that tiger. So you have to know some anatomy. So these are the kind of maps now that clinicians have worked out, research, in dissecting rooms with anatomists and latterly with computing scientists and with engineers. For example, dermatomes. When you feel in your skin, you can feel whether it's hot or cold, you can feel your finger, you can feel a pinprick, something blunt or sharp. And the way the skin is organized, or the nerves to the skin are organized, they supply the skin. Each spinal nerve and all of its branches supply an area of skin called a dermatome. Around the trunk, they go around in overlapping rings, and they're pulled out over the arm and the leg, because that's just the way the arm and the leg grow. But by knowing the dermatome mapping, you can help to understand the level of a spinal cord injury. You can interpret, say, a slip disc, and you can interpret something like shingles. Because there's shingles, the little vesicles there, which are trailing along in sort of T4, the fourth thoracic segment. And you can see that. I'm terrified of this thing. I've got a real complex. I'm going to press the wrong button. But there you can see there's the T4 just there. And then there's another very interesting map that is absolutely essential for anybody who's having reconstructive surgery to fill in a big defect And this is the concept of angiosomes. It's a different kind of map. It's a map. A lot of the work for this was done in New Zealand by an extraordinary team led by Professor Ian Taylor. But they wanted to know how to improve the kind of flaps that are put over these defects, because the skin would die sometimes. Why? What don't we know about the blood supply of the flap? And what they discovered was that each area of skin on there has its own what's called perforating branch that comes from a source artery underneath. And if you know where the perforating artery is, then you can take out the skin around it and you can plug that in, maybe with the underlying muscle, you can plug it into the defect and the skin should survive. The workhorse, when I was talking about this last evening to a maxillofacial surgeon, the workhorse flap is the flap on the side of the thigh, on the outer side. If you feel the knobbly bit of bone up here, the anterior superior iliac spine, and you go down just to the outer edge of your kneecap, your patella, and you draw a straight line there, and you go down to halfway down, and you do a circle round, which is 6 centimeters across. That's where you'll find the perforator for the anterior anterolateral thigh flap. And that flap is used for, putting in the tongue, for example. Someone had cancer of the tongue, supplying half the tongue. And there, for example, I've just shown you that there's a flap. Someone has obviously had a huge defect, maybe a cancer or maybe a burn on the great toe. And there is a flap that is going to be used there, plugged in from the medial tibial branch of the posterior tibial artery, medial plantar artery, I beg your pardon. And you may say, what on earth happens to the defect? Well, that's filled in with a skin graft. And then we have all sorts of maps, again, which are used, functional maps of areas of here, for example, bronchopulmonary segments. These are individual segments of the lung which are based on segmental bronchi. Someone who puts a bronchoscope down will investigate each one of these to look at if there's any pathology, and they can be removed. The segments can be removed. They have their own bronchial supply, their own arterial supply, but they don't have their own venous. They share a venous. Liver segments. There are 8 segments of the liver based on the 3 hepatic veins. And this kind of information is absolutely essential for hepatic surgeons, liver surgeons, who are resecting, taking out part of the liver or transplanting a liver. And then cancer specialists have to know maps of the lymph nodes that are draining each of the organs, because they will be resected. And again, these are maps, all of these maps have been devised with surgeons and with anatomists particularly. And this one, for example, the one up at the top here, some of the research on that started at the beginning of the 20th century with corrosion casts. Quite extraordinary. So those are the sorts of maps that anatomists and surgeons and clinicians use. So, clickable anatomy, it is a word, clickable. I looked it up, it's Scrabble approved. But I thought, I've got to make sure, because I think clickable, is that really true? But this was a comment I saw very recently. Tech-savvy students, particularly if you don't dissect, how can you learn anatomy? Well, you can learn it. You can go online. Extraordinarily, you can dissect, look at sections, interactive sections, which will give you the answers. You can do the same with images here. Quite extraordinary. You can scroll through. It will label things for you. I had some fun the other day. I thought I'd have a look at this for you. I went on to the surface anatomy, and I thought I'd just click in mid-clavicular line, and goodness gracious me, those green dots appeared. It's a wonderful way to learn your anatomy. And just look at this, Radiopedia, which is an incredible site. Nearly 50,000 cases from which you can learn. You can learn with virtual reality, and you can learn on the bus, but I don't advise it, okay? So just finally then, 5 quotes, and I wonder if you can guess the length of time between them. Anatomy is the basis of medical discourse. Pupils should study the diseases that affect different organs, but must first study the anatomy of these organs. All physicians should undergo training in anatomy. The basis of all medical skills is a knowledge of anatomy, and a good understanding of anatomy and physiology is essential for all medical students. Well, the first one is Hippocrates, a long time ago. The next one is Avicenna. And the next one is the Holy Roman Emperor Frederick II. At that stage, they knew almost no anatomy, but somehow there was this feeling that you should know anatomy, you should be conversant with it in order to treat your patients. This one is those lovely people in Massachusetts again. They're obviously very thoughtful about their anatomy, legalizing the study of anatomy, but this is, of course, before anesthesia, and this one is the Royal College of Surgeons of England and its undergraduate surgical curriculum. So from the beginning, even before people could dissect, could look into the body, there was this sense that anatomy is incredibly important. It's called a basic medical science, it's a fundamental. Above all, do no harm. Know your anatomy. And as I say to my students, if you don't know it, don't guess. So thank you very much for listening.